You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for July 29th, 2022. This week, big news in heart failure and electrophysiology, doctors and probability, left ventricular assist devices and cardiogenic shock, vitamin D, and exercise that induces pain. The first topic today could represent the biggest news in EP since the major CRT BiV trials that showed that BiV pacing improves outcomes in patients with left bundle branch block and heart failure. Listeners know that I am an ardent supporter of conduction system pacing, first in the His bundle, but now in the area of the left bundle branch on the left side of the septum. And I admit that some of my attraction to this technique is the aesthetics. Pacing the conduction system delivers gorgeously narrow QRS complexes. And of course, another attraction is plausibility, meaning that if you pace the conduction system, you restore right and left ventricular synchrony. That will A, eliminate pacing-induced cardiomyopathy, and B, could function as a replacement for BiV pacing in CRT. But listeners also know how often I rail against doing things because they are plausible or make sense. Someone could say, Mandrola, you're a hypocrite. As a medical conservative, you say we ought to have trials before adoption. And these critics would have a point, except this week we learned that there likely will be a trial. My colleague, Mihail Chalou from Baylor University and Ken Ellenbogen have garnered $31 million from the U.S. government from the Patient-Centered Outcomes Research Institute, PCORI, to conduct this trial. It's called Left versus Left Randomized Clinical Trial. And it will test conduction system pacing versus BiV pacing in those eligible for a CRT. I'll link in the show notes to the press release. And in it, Dr. Chalou describes a 55-center trial in the U.S. and Canada that will plan to randomize more than 2,000 patients who are eligible for CRT to either conduction system pacing or standard BiV pacing. It'll be a 5-year trial, and the endpoints are strong: death and heart failure hospitalizations. I'm extremely proud to say that my shop, Little Old Baptist Health Louisville, will be a center. And I will issue this challenge to the other big-name centers. We will challenge you for top enrolling sites. And I say this because while I love conduction system pacing, and I do it all the time, I also love evidence, and the CRT proponents are exactly correct. We need data. There's true equipoise in this situation, so congratulations to Dr. Chalou and Dr. Ellenbogen. This is huge news. Okay, second topic is probability. Now, let me tell you a story that is a bit related to the topic of BiV pacing that I just mentioned. A partner says to me, John, I got this BiV device would really help my patient. And he's right. This was a female patient, non-ischemic, typical left bundle, first degree AV block. These are all good predictors for CRT response. And my partner also told the patient it's like a 95% chance of benefit. Now that statement almost gave me a rash. I said, you told them what? Yeah, she'll do great. Now, why am I anxious about this? I'm anxious because of what's called the conjunction fallacy. That is, the idea that probabilities don't add, they multiply. Recall that probabilities are less than 1, so when you multiply them, they get smaller. But before I tell you about how the conjunction fallacy relates to the cardiac procedure of doing a BiV CRT device, let me give you the famous example of the conjunction fallacy, and this was made famous by Tversky and Kahneman. They called it the Linda problem. Here it is. Linda is 31 years old, single, outspoken, and very bright. She majored in philosophy, and as a student, she was deeply concerned with issues of discrimination, social justice, and also participated in anti-nuclear demonstrations. So the question that Tversky and Kahneman asked, which is more probable? 1, Linda is a bank teller. 2, Linda is a bank teller and is active in the feminist movement. Now, the majority of people in their experiments chose 2, but that is wrong. And it's wrong because the probability of 2 events occurring together, that is in conjunction, is always less than or equal to the probability of either one event occurring alone. Now, Tversky and Kahneman argued that most people get this problem wrong because they use a heuristic, a shortcut, called representativeness to make this kind of judgment. And here option 2 seemed more representative of Linda from the description of her, even though it is clearly mathematically less likely. Now, we doctors use tons of heuristics. Now, let me go back to the CRT by V pacing example. There are tons of conjunctive probabilities here. There's the probability that there are adequate coronary sinus veins. Then there's the probability that I'm able to get a lead in them. The probability that the vein will have a good threshold without phrenic nerve capture. Then there's the probability that these leads cause her to be a CRT responder. And then there's the probability that she heals the incision without infection. Now, all of those are decently high probabilities, but I guarantee that multiplying them together does not get to that 95% that my partner told the patient. JAMA Network Open has published a brilliant study led by Scott Abereg from the University of Utah, first author Hal Arkes from Potsdam, Germany, in which they ask whether physicians are able to correctly estimate the overall probability of a medical outcome resulting from a sequence of clinical events. Now, sequence of clinical events are very common. The authors sent out surveys that consisted of 3 separate sub-studies to more than 200 doctors. The docs were asked to estimate the probability of success of each of the components of this diagnostic or prognostic sequence, as well as the overall probability of the sequence. And all these docs were board certified in the specialty of the scenario. 2 of the sub-studies were obstetrics cases. In 1 sub-study, it was a pulmonary case with evaluation of a pulmonary nodule. Now, the pulmonary nodule one's easier to get at. Here's what it was. The docs estimated the probability that the patient had cancer and the probability that a needle biopsy would reveal cancer. Of course, these were doctors in their 50s on average, so they were experienced. And sit down for the results. Of the 215 doctors who responded, 168 or 78% estimated the probability of the 2-step process as greater than the probability of at least 1 or 2 of the component events. And it wasn't by a little. They estimated the final probability of the process by 12 to 20% higher than the single elements. My friends, let me remind you that these are formally illogical and mathematically incoherent answers. So the authors concluded that this biased estimation, consistent with the conjunction fallacy, may have substantial implications for diagnostic and prognostic decision-making. Now, commenting on the study in the news story on Medscape Medical News, Adam Rodman from Beth Israel in Boston said, quote, if, as his paper shows, physicians fundamentally misunderstand the multiplication rule of probability due to innumeracy, they are dramatically overestimating the post-test probabilities of disease and drastically overtreating people. And of course, this idea is backed by the famous experiment from Gerd Gigerenzer. And this is when he asked doctors to calculate the probability that a woman had breast cancer from a positive mammogram. And in his example, more than 90% of doctors responded with an estimate 10-fold higher than the correct answer. A senior author, Scott Abereg, said this about his paper. He said, it really seems as though in this study and in my experience in medicine that when asked to predict a probability, physicians are either completely unwilling to do so or provide nothing more than a wild guess. And he said, that sounds pejorative. It sounds like I'm joking or poking fun at my fellow physicians, and I don't want to seem that way. But I think it just reflects the general discomfort with or lack of facility with probabilities and simple numbers. Now, here's my take. Yes, I agree that physicians, including myself, are not that facile with probability. It's why we are so easily bamboozled by studies. But the main problem with our widespread allergy to probability is that it makes us way too confident and way too optimistic. Now, my partner earnestly telling the patient that there was a 95% chance of CRT benefit, for instance. Or the idea that something like AF screening or vascular screening will lead to benefits. Now think of the multiple components on that chain of probability from a rhythm screening device to a longer, better life. Now, as for the solution, Abereg is right when he says medical education should redouble its focus on probabilities. I think that Kahneman's thinking fast and slow ought to be taught in the place of Krebs cycle, or it ought to be taught every year in medical school. Well, Kahneman wasn't right about everything, but this work helps us understand our human weaknesses of thinking. And this, of course, would make us better doctors. Kudos to Scott and his colleagues. Now, third topic, assist devices in cardiogenic shock. Cardiogenic shock's bad, right? Simply stated, it occurs when the cardiac output is not sufficient for organs to function. An acute MI or heart attack is the most common cause of cardiogenic shock. Now, doctors sometimes used assist devices, which makes perfect sense, right? Now, the old one is called the intra-aortic balloon pump. The balloon pump works by inflating and deflating in the aorta, and this enhances cardiac output, but by less direct means. When the balloon pump inflates during diastole, it improves coronary blood flow. When it deflates during systole, it acts sort of like a suction device pulling blood out of the heart, so-called afterload reduction. Now, a commonly used newer assist device is called an intravascular microaxial left ventricular assist device. This device goes across the aortic valve in the LV. Basically, it grabs blood from the LV and pumps it out to the aorta and adds to the cardiac output up to 3.8 liters of cardiac output, which is a lot. Now, I usually shun brand names, but the most common microaxial left ventricular assist device is made by ABL Med and is called Impella, and everybody knows this. The journal JAMA Internal Medicine has published another observational study comparing the LVAD, the Impella, to the balloon pump in patients with cardiogenic shock. This was a Yale-led team of authors, first author P. Elliott Miller, and they looked at short-term clinical outcomes in the two different devices. They used administrative insurance claims data. Now, obviously these two groups, LVAD versus balloon pump, were not random, so they used propensity matching in an attempt to match as many baseline variables as possible. The sample size was about 3,000 patients, and of these they were able to find about 800 matched pairs. And they found that patients treated with the Impella were 63% more likely to die in the hospital, 71% more likely to die at 30 days, 44% more likely to die at 1 year, and all of these were statistically significant. They also found that bleeding at 30 days was higher in the LVAD arm. Dialysis was 88% higher, and that was also significant, and for the win, costs were $50,000 higher in the LVAD group. So my comments, on the surface, this sure looks bad. The Impella LVAD costs more and is associated with more death, more kidney failure, more bleeding. What's more, crazily, it's compared against a therapy balloon pump found in meta-analyses to be no better than medical therapy. Pause there for a second. The Impella was worse than a device that was no better than medicines. I'll link to the meta-analysis. I think the best one is from first author Ahmed, published in JAMA Internal Medicine. Now, thus far, there are no RCTs of the Impella LVAD in cardiogenic shock that look at outcomes. There is, however, one that is ongoing, an important one called Danger Shock trial. It's randomizing Impella versus guideline-driven therapy, and it's going to look at mortality at 6 months. For now, though, all we have are small trials of the Impella LVAD versus aortic balloon pump, which don't have the power to sort out outcomes. So we don't know. And previous observational studies have found worse outcomes with the Impella LVAD relative to the balloon pump, just like this one. And it's also plausible too, right? The Impella device requires a large bore arterial access. This may increase the risk for bleeding. It's in the left ventricle, and it could increase stroke or emboli to the kidneys. Also, the placement of this device may delay revascularization. In other words, doctors are dorking around with that, may distract from opening the artery, which is the problem. So there are reasons why this observational study may be true. But, and I hope you all know what is coming next. You cannot make this causal leap that these studies are enough to tell you that the LVAD Impella are worse than the balloon pump, which is no better than meds. And that's, of course, because that sicker patients might have received the LVAD. They might be different, and that is why they fared worse. I mean, propensity matching tries to balance these differences out, but that is not a substitute for randomization. And what's more, and I'm no expert in this, but I have trouble believing that insurance claims data is granular enough to make these sorts of adjustments to even get close to randomization. Now, you may counter this and say, well, Mandrola, this isn't the only observational study showing harm. There are others, and I would agree with that, but I would counter that it could be like the digoxin story, meaning that all the observational studies are likely confounded by indication or selection bias. Here is the core existential problem with observational studies. Sometimes they align perfectly with trials. You just can't know which ones these are. I got that quote from Dr. David Cohen. Well, finally, there's an excellent editorial by Gene Hugh and colleagues, and they state that the AHA, American Heart, has released a policy statement for patients with MI that, quote, for those with cardiogenic shock at presentation or during hospitalization, treatment with advanced mechanical circulatory support devices should be initiated early, and that centers without these capabilities should have means to transfer patients. Really? Well, I don't think this and other observational studies prove harm, but I would also say there's no compelling evidence that the far more costly device is worthy of such a statement from the American Heart. I also agree with the editorialist in that there was regulatory failure in this space. The LVAD Impella use has ballooned in recent years. Of course, there is a billing code for it, and doctors get more RVUs for doing it. So why wouldn't regulators make proponents show that a more expensive, more invasive device works before allowing it? Imagine the counterfactual world where regulators said, sure, you can use this device and we'll pay you for it, only it has to be part of a trial. We'd already know the results. Now imagine if the danger shock trial comes out no difference, null, non-significant, or worse, higher mortality in the Impella arm. Think of the money and potential lives that would have been saved with proper evidence before adoption. And it's the same story, by the way, with Watchman. If regulators had required evidence with reimbursement, we would know if this device works. Okay, next topic, vitamin D. This is a quick one. New England has published yet another trial looking at supplemental vitamin D to improve health. This podcast has covered vitamin D over and over again, and all these trials have failed to show benefits in cardiovascular health. Now, the one place where vitamin D supplements would seem most likely to help is bone health. In fact, previous trials have shown some conflicting results, but last year the neutral judges from the USPSTF found no effect of vitamin D on fracture incidence among adults with low vitamin D levels. So this most recent trial was an ancillary study of that very large trial called VITAL, which was published in 2019. It has 25,000 patients. Vitamin D and fish oil was given in the original trial versus placebo. And vitamin D led to no reductions in major adverse cardiac outcomes or invasive cancer in the 2019 publication. Now, this publication, I could give you all the hazard ratios and confidence intervals, but suffice to say, there were no differences in fractures, and not even a modification of treatment effect according to baseline variables such as low baseline vitamin D levels. And I think the editorialists have this very helpful sentence, which I'll read to you. They write that the results of analyses from vital studies published in peer-reviewed journals have shown the following. Vitamin D did not prevent cancer or heart disease, did not prevent falls, did not prevent cognitive dysfunction, did not reduce AFib, migraine frequency, it did not improve stroke outcomes, decreased age-related macular degeneration, and it didn't even reduce knee pain. So the editorialists also remind us that more than 10 million vitamin D levels are done annually to screen for low vitamin D. They suggest that this practice of screening should stop, as should treating to a target vitamin D level. And I would add that we could stop burning money researching this question. And the only remaining question I have for vitamin D is why this therapeutic fashion has been so resistant to evidence. Final topic today, also a quick one, is on peripheral artery disease. Most of the atherosclerosis I discuss on the This Week in Cardiology podcast is in the coronary arteries, but so-called peripheral artery disease is also common. We call it claudication when stenoses in the leg arteries cause exercise-induced pain that resolves with stopping. And I have a bunch of patients whose exercise is limited by claudication. Now, these stenoses in the legs can be bypassed or stented, and of course, medical therapy such as statins help as well. The journal American Heart Association has published results of a trial, randomized controlled trial, looking at another way to manage these patients, and that is with exercise, but not just any exercise through the pain of claudication. The trial was called LITE, L-I-T-E, and it was led by a team at Northwestern. I randomized patients to a home-based walking exercise program that actually induced ischemic pain versus an exercise program without ischemic pain or a non-exercising control arm. And the primary outcomes was change in walking speed and a performance questionnaire. Now, the results were that the group that walked to pain did better. The group that just walked without ischemic pain, even for longer distances, did no better than a non-exercise control arm. Now, I think I knew this, but still, when you look at the graphs, there was a significant difference in the pain group, and the group that walked but didn't go to ischemic pain had really no difference. Now, I used my phone a friend policy, and I talked with our vascular surgeons, and they're a funny group. One said, walking programs work, but no pain, no gain. Another surgeon said, it's amazing that cardiology is doing a study that has been proven in vascular surgery for 50 years. He speculated probably the reason for the study is the change in approach that's been brought on by endovascular therapy, that is angioplasty and stents. A third surgeon said, you walk until it hurts, then you walk some more, then rest. He said at least 30 minutes, at least 3 times a week. This is decades-old advice. And one of the surgeons told me that their group is highly, highly reticent to intervene on disease below the inguinal ligament in the legs. Yes, he said, it relieves claudication quickly and effectively, but they worry that the future risk of amputation is greater. Why? Because stents in the periphery are smaller and it doesn't take much hyperplasia to shut it down. He said that the vascular surgeons are in the limb salvage business. He also emphasized how strongly they optimize medical treatment. They do get people to stop smoking, and they do use very high-dose statins. And it was funny listening to him go on so vigorously about medical therapy. A surgeon made me wonder if they're not more aggressive with peripheral artery disease than we are with coronary disease. Of course, vascular surgeons don't have these big, bright, flashy nuclear scans that say ischemia, danger, and then we better go to the cath lab. So I close with this topic because, as a retired bike racer, the fact that we have strong evidence that exercise to the point of pain and it's actually beneficial makes me happy. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, friends, if you like this podcast, please give us a rating. Write us a 1 or 2 sentence review. These sorts of small little things help others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.